Hey guys, welcome to your online lecture, Care of Clients Experiencing Stroke and Rehab Following Stroke. So, stroke occurs when there is ischemia to a part of the brain or hemorrhage into the brain that results in death of brain cells. Ischemia happens when there is inadequate blood flow. Overall, movement, sensation, and emotions can be affected depending on what area of the brain is affected by the stroke. Immediate medical attention is of utmost importance when we are caring for clients with a stroke. If you review this video in slideshow format, there is a video here on the right which talks a little bit about the patho of stroke and the two different strokes, hemorrhagic and ischemic. So here are some Canadian stroke stats from 2011. Overall, the brain requires blood flow to provide oxygen and glucose that our neurons need to function. The brain is usually protected from a change in the mean arterial blood pressure over a range of about 50 to 150 millimeters by a mechanism known as cerebral autoregulation, which can be impaired following a stroke, which is what leads to the change in blood pressure. Factors that affect blood flow to the brain include blood pressure, cardiac output, and blood viscosity. Here are a few more stats. Of every 100 people who develop a stroke, 15 of them will die, 10 will recover completely, 25 will recover with a mild disability, 40 are left with a moderate to severe disability, and 10 are completely disabled and will require long-term care placement. For every minute delay in treating a stroke, the average patient will lose 1.9 million brain cells. Each hour that treatment does not occur, the brain loses as many neurons as it does in almost 3.6 years of normal aging. The average acute care cost of stroke is about $27,500 per individual who suffers a stroke. Canada spends $3.6 billion a year on stroke care, and Canadians spend a total of 300 million days in the hospital due to a stroke. So the patho behind it we'll talk a little bit about, but I know that Siobhan went into a lot more detail about it. So the internal carotid and the vertebral arteries supply blood to the brain. When this blood flow is interrupted, for example in a cardiac arrest, we get the following effects. Neurological metabolism is affected in about 30 seconds. This metabolism will stop in 2 minutes, and cellular death occurs in 5. Atherosclerosis is a major cause of stroke. It can lead to thrombus formation and emboli or clots. Inflammation is a key factor in the development of atherosclerosis. As LDL cholesterol accumulates in the arterial wall, it undergoes chemical changes and signals to the endothelial cells to latch on to white blood cells circulating in the blood. These immune cells will penetrate the intima and trigger an inflammatory response, devouring the LDLs to become fat-laden foam cells. And then they will form a fatty streak, which you can see in here. This is the earliest stage of atherosclerotic plaques. The plaque will continue to grow and form a fibrous capsule. Substances will be released by foam cells and can eventually destabilize the cap, allowing it to rupture. This will then form a blood clot. This blood clot can block flow and trigger a heart attack or stroke, because pieces of the plaque can break free and travel to the brain. When it travels to the brain, it blocks blood vessels that supply blood to the brain, and this is when we have an ischemic stroke. Some of the non-modifiable risk factors for stroke include age, gender, race and ethnicity, and family history. Other non-modifiable risk factors include the fact that after age 55, your risk of a stroke will double each decade. 2/3 of all strokes occur in individuals age 65 and older. Women tend to live longer, which means they have an increased risk for stroke. Some of the modifiable risk factors include hypertension, which is the single most important risk factor for stroke that we can modify. Heart disease such as AFib, cardiomyopathy, stenosis, and valve abnormalities and defects increase the risk. The most important treatable risk factor in regards to heart disease is AFib. 25% of all stroke cases greater than 80 years of age are because of an underlying AFib. The risk of thrombus formation with individuals with AFib is quite high. Diabetes is also a significant risk factor for an ischemic stroke. For someone who is diabetic, they are 4 to 5 times more likely to have a stroke. Therefore, testing the hemoglobin A1C every 3 months is very important so that we can assist in modifying the diabetic patient. BCP, or birth control pills, high levels of estrogen and progesterone increase a woman's chance of stroke, and therefore low-dose oral contraceptive pills are the most effective at decreasing the risk for stroke. TIA's, transient ischemic attack, is a temporary focal loss of neurological function. It's caused by ischemia of one of the vascular territories of the brain. Usually when an individual has a TIA, it lasts less than 24 hours and often is very quick, lasting less than 15 minutes. So they may have sudden onset stroke-like symptoms that then reside or go away quite quickly. It may be due to microemboli that temporarily block the blood flow, and then quickly the blood flow is restored and the symptoms resolve. These TIAs can occur singularly, or a patient can have multiple TIAs over a period of time. TIAs are very much a warning sign of progressive cerebrovascular disease and can lead to a full-on stroke. Signs and symptoms depend on blood vessel involvement and the area of the brain that is blocked. It can include temporary loss of vision in one eye, paralysis on one side of the body, numbness, tingling, an inability to speak or slurred speech, ringing in the ears, dysphagia, or weakness. Ischemic strokes result from inadequate blood flow to the brain. It may be from a partial or complete occlusion of the artery. A TIA, like talked about in the previous slides, is a precursor to an ischemic stroke. Ischemic strokes can be classified as thrombotic or embolic. Thrombotic occurs from an injury to a blood vessel wall and formation of a blood clot. The extent depends on the onset and the size of the lesion. In a thrombotic stroke, the symptoms can worsen for 72 hours after the initial event because edema is happening in the brain. An embolic stroke occurs when an embolus lodges and occludes a cerebral artery, resulting in infarction and edema of the area. It's the second common cause of stroke. The majority of embolus start in the heart and travel to the cerebral circulation and lodges in the brain. The patient with heart disease, prosthetic valves, and AFib are at high risk of embolic strokes. The patient with an embolic stroke has a rapid occurrence of symptoms. The prognosis is related to the amount and location of tissue that is deprived of blood flow and effects characterized by severe neurological deficits. The recurrence of this type of stroke is common if it is not treated aggressively. The second type of stroke is hemorrhagic. This type of stroke is less common, but it results from bleeding into the brain itself. We will discuss this further shortly. Ischemic stroke again results from inadequate blood flow to the brain from a partial or complete occlusion of an artery. It's by far the most common stroke that you will see, occurring in about 80% of all strokes. Thrombotic stroke, so plaque causes fatty deposits, which lead to clot formation. These clots will then block the artery and the passage of blood. On the other hand, we have embolic stroke. So a blood clot, or embolus, is circulating in our blood. It becomes lodged in an artery in the brain because it's too narrow to pass through it. So the clot is too large, the artery is too narrow. It occludes the artery, blocks blood flow, and provides symptoms for the patient. Hemorrhagic stroke is less common, accounting for 15% of all strokes. It results from bleeding into the brain tissue itself, known as an intracerebral hemorrhage, or bleeding into the subarachnoid space of the ventricles, known as a subarachnoid hemorrhage. Prognosis is very poor with a hemorrhagic stroke, with a 30-day mortality rate of 40 to 80%, with over 50% of individuals suffering a hemorrhagic stroke dying soon after the event. With an intracerebral hemorrhage, there's bleeding within the brain caused by a rupture of a vessel. Hypertension is a significant cause, and that's why it is a reason that we really do want to educate our patients in regards to hypertension and getting their blood pressure under control. It commonly occurs during periods of activity, and the symptoms include sudden onset with progression of over minutes to hours related to ongoing bleeding. So usually the bleeding is quite slow, and then it gets bigger and bigger over a period of time. Neurological deficits such as a severe headache, nausea, vomiting, altered LOC, and hypertension can occur. You can see here on the left a normal CT of a slice of the brain, and then on the right, the white area is the hemorrhage. Ischemia usually shows as very black, so this would all be black, whereas hemorrhage shows as white. A subarachnoid hemorrhage is when intracranial bleeding into the cerebral spinal fluid-filled spaces between the arachnoid and pia mater membranes of the surface of the brain occurs. This is commonly caused because of a rupture of the cerebral aneurysms. Again, the patient would experience significant headache, altered LOC, focal neurological deficits, nausea, vomiting, seizures, and a stiff neck. This is a picture of the subarachnoid hemorrhage, which you can see in this area of the brain with the white. So there are two main causes of hemorrhages in the brain. One is an aneurysm, so a weak area in the wall of the blood vessel fills with blood and bulges outward. High blood pressure can cause this bulge to rupture. Again, 40% of these people will die during the first episode and 15% in subsequent bleeding. The incidence increases with age and is higher in women because they live longer. Overall, aneurysms are the silent killer because there are no warning signs of them until they actually rupture and bleeding occurs. Remember, different parts of the brain control different functions. When someone has a stroke, the functions that are affected will really depend on the area of the brain that was damaged and how the damage occurred. Effects of a stroke can be dramatically different among different people. It's based on neural findings alone. If based on neural findings alone, you cannot differentiate between hemorrhagic and ischemic. The only way to differentiate between a hemorrhagic or an ischemic stroke is to do a CAT scan of the brain. I'm going to stop this video here, and there will be a second part to it.